Buenos noches! Today we're going to talk about diabetes complications. Firstly, the long-term complications. We'll go over microvascular and macrovascular. We'll go over some signs and symptoms of insulin, using insulin and monitoring parameters and things like that. So long-term complications, microvascular. We've got ocular complications, so your eyeballs. You can get blurred vision. You can get cataracts, which leads to glaucoma. You can get retinopathy. You'll start seeing little patches in the back of your eyes. You get nephropathy, so your kidneys, they're constantly getting sludge, all that sugar in your blood. Neuropathy, this can be peripheral, so you get paresthesia in your fingers and toes. GI neuropathy, which can lead to gastroparesis, so your stomach usually does peristalsis like this, but it just isn't doing this anymore, so you can't move food along. You can get urinary retention, postural hypotension, and then erectile dysfunction. Macrovascular complications, see, these are your big blood vessels. You can get ASCVD, so atherosclerotic cardiovascular disease. So you get plaque in those arteries that can lead to stroke and MI. Another one is stroke. You're more likely to have stroke if you have uncontrolled blood sugars. And then peripheral vascular disease, so you get bad blood flow to your peripheries. So then they chop off your leg.
Oh my gosh.
Also periodontal disease, so your teeth. So let's go over some monitoring. So blood glucose, you monitor that. Fasting blood glucose, so this is about when you haven't ate anything. So in the morning, should be from 80 to 130 per the ADA guidelines. Postprandial blood glucose should be less than 180, so about an hour after you eat, it should be less than 180. A1C, that's a 3-month tell-all of how high your blood sugar has been over the past 3 months. So it should be less than 7%. So let's talk about insulins now. There's different types of insulin. There's regular insulin, there's NPH, there's long-acting and short-acting. So let's talk about regular insulin. This is the only kind you use IV. It onset's about 2 to 3 hours, and duration, it lasts about 4 to 6 hours. Then we've got our long-acting, which is Glargine, Detamir, and Degludec. Glargine, about 4 to 5 hour onset and lasts about a day. Detamir, same, 2 hour onset, lasts about 14 to 24 hours. And then Degludec, this one's the long-acting one, Tresiba. Its onset is about 1 to 2 hours and it lasts about 40 hours. We've got our short-acting, Aspart, Lispro, and Glulisine. Onset's about 15 to 30 minutes, and it lasts about 3 to 4 hours. This is the one you take right before you eat or right after you eat. Then we've got NPH, lasts about 12 hours. You take it twice a day. Onset, about 2 to 3 hours. So factors altering insulin action. So IV is obviously faster than IM, which is faster than sub-Q. Injection site, your stomach, injecting it in the stomach, it acts faster than in your thighs or your buttocks. Temperature, heat increases the absorption and action of insulin. So if you're exercising, get a massage, increases the absorption and action of the insulin. Prep and mix, U500 has a delayed onset, peak, and longer duration of action compared to U100. So U500 is more concentrated insulin, so you can give less, but still give the same amount, if that makes sense. Dose, smaller volumes increase absorption because there's more surface area to grab on and it absorbs better. Compliance, errors, renal function, renal failure decreases insulin clearance, therefore it acts longer, so it increases the action of insulin because it's around longer. Stability, vials are stable for 28 days, except Levemir, which is 42 days. Put vials and pins not in use in the fridge. Regular and NPH, when you mix them, 7 days in the fridge, you always draw the short-acting first, so the regular first. Short-acting with NPH, give immediately, don't store in the fridge. Long-acting, you never mix long-acting. Complications of insulin, hypoglycemia. Causes for hypoglycemia, you increased your insulin dose. Makes sense. So what is hypoglycemia? Low blood sugar, right? Decreased caloric intake, you're not eating as much, so there's more insulin, and you don't need as much insulin, so your blood sugar drops faster. Increased muscle utilization, it's good stuff. Excessive alcohol use, hypoglycemia. Signs and symptoms, tremor, tachycardia, diaphoresis, slurred speech, drowsiness, weakness, blurred vision. It's important to know that beta blockers will mask some of these signs like the tachycardia and the diaphoresis. Now, what do you do if you have hypoglycemia? If your blood glucose is, you take 15 grams of simple carbs, so that'd be like a 12-ounce Coke or a couple Lifesavers, things like that. Simple carbs is the point, simple. You take 15 grams of simple carbs, then you wait 15 minutes and check your blood glucose. If your blood glucose is less than 50, then you take 30 grams. So you can repeat this if it's not above 70, but if it's above 70, you stop. If you're unconscious to the point, you can use glucagon 1 milligram sub-Q, IM, or IV. Another complication of insulin is weight gain because you can actually use the blood glucose. Lipohypertrophy from repeated injection site using. So if you shoot yourself in the thigh the same place every time, you could get this lump. And you can get lipoatrophy, which is an immune reaction from antibodies or allergic reaction, and there's like a dent in your skin. So hypertrophy, atrophy, hypertrophy, atrophy. And that is it. Adios, amigos.